Imagine for a second that that you're someone who just loves to cycle.
Okay.
Like you've been doing it your whole life, right? It's your stress relief. It's your weekend ritual.
Yeah, a lot of people are like that.
Right. But then seemingly out of nowhere, getting on the saddle, just it becomes uncomfortable.
Mhm.
And then a few months later, it's not just uncomfortable, it's actively painful. Like the friction is unbearable.
Yeah.
So you give up the bike.
Right.
But then sitting at your desk for too long starts to burn. And eventually, even being intimate with your partner becomes so agonizing that you start avoiding it entirely.
It's awful.
It is. And then you go to a doctor expecting, a solution.
Yeah.
And they basically shrug and tell you, well, that's just part of getting older.
Yeah, it's a devastating scenario.
Mm-hmm.
And I think the most shocking part is just how incredibly common it is.
Right.
I mean, millions of women experience these profound, really painful changes to their intimate anatomy. And for decades, the medical establishment offered almost zero recourse. You were literally just expected to suffer in silence.
Which is why, when you contrast it with almost any other area of medicine.
Oh, absolutely.
Because usually there's this expectation of precision, right? Like visibility.
Yeah, you want to see the problem.
Exactly. If you break your arm and X-ray shows that jagged white line, the doctor points to it, and you immediately know the protocol to fix it. We love things that are visible.
Right.
But you step into the world of women's intimate health, specifically the functional changes triggered by, aging or menopause or childbirth, and suddenly that X-ray machine is just completely useless.
Totally useless, yeah.
The diagnostic landscape has historically just been murky because the damage is largely invisible to the naked eye.
Right, but the word invisible is doing a lot of heavy lifting there.
What do you mean?
Well, the damage was invisible to doctors who weren't trained to look for it, or who, frankly, didn't take the complaints seriously.
Ah, okay.
But today, we know exactly what is happening down to the microscopic cellular level.
We can actually see it now.
Yes. We know the molecular mechanisms of this pain, and more importantly, we finally have the clinical tools to actually reverse it.
Right.
Rather than just telling patients to endure it.
And that brings us directly to the massive stack of sources that we're unpacking today for this deep dive.
Yes, we have a lot to get through.
We really do. We've pulled together clinical studies from the Journal of Menopausal Medicine, an incredibly detailed master's thesis on aesthetic and functional gynecology from the Lithuanian University of Health Sciences, and a whole variety of contemporary expert clinical guides.
It's a very rich collection of data. It spans everything from the raw cellular biology of tissue degradation to real-world quality of life patient outcomes.
Yeah, and our mission for this deep dive is to basically synthesize all of this data to answer a highly specific but genuinely fascinating medical question.
Right.
Which is, can labial filler augmentation, specifically using hyaluronic acid, be safely and effectively combined with topical estrogen therapy to treat concurrent dermal thinning and epidermal dryness?
Which is such a vital question to explore. We are talking about targeting two completely distinct mechanisms of aging that just so happen to occur at the exact same time.
In the exact same region of the body.
Exactly.
My overarching takeaway from diving into these sources is honestly just sheer enthusiasm for how far the science has progressed.
Oh, for sure.
Like, we are treating quality of life issues that were ignored for centuries. But before we get into the mechanics of this combination treatment, we have to kind of isolate the root of the problem.
Right, we have to know what's breaking down.
Exactly. What exactly is breaking down in the tissue to cause both this severe thinning and this agonizing dryness?
So to map that out, we have to introduce two terms that just dominate the clinical literature in our sources.
Okay.
The first is GSM, which stands for genitourinary syndrome of menopause, and the second is VVA, vulvovaginal atrophy.
And now those sound like very dense, abstract medical categories.
They do, yeah.
But they really represent a physical cascade that's triggered by one single primary biological event, right?
Yeah.
Which is the drop in estrogen.
Yes. Estrogen is the absolute master regulator for the tissues in the female reproductive tract.
The master regulator.
So master regulator. So the moment estrogen levels plummet, whether that naturally occurring during menopause or postpartum after giving birth, or even medically induced from treatments like chemotherapy,
Okay.
the tissue goes into this profound state of deprivation.
Wow.
So let's tackle the epidermal dryness first.
Yeah, let's start there.
When estrogen drops, the actual mucosal lining of the vagina undergoes a dramatic physical thinning.
And the sources get highly specific about the cytology here, like the actual architecture of the cells.
Yes.
I was reading about a complete shift in the dominant cell types.
Right, let's visualize what that looks like.
Yeah.
So in a healthy estrogen-rich environment, the vaginal lining is built like a robust brick wall made of what we call superficial cells.
Okay, superficial cells.
Yeah, these are mature, plump, highly hydrated cells.
Right.
They are literally built to withstand friction and maintain moisture.
Okay.
But when the estrogen supply is cut off, those plump superficial cells completely vanish.
Just gone.
Gone. The body replaces them with a predominance of parabasal cells.
And parabasal cells are essentially the immature, weaker versions of the cells, right?
Indeed.
Like they haven't fully developed their internal capacity to hold on to moisture.
Right. They are small, they are fragile, and they lack one crucial defining component, which is intracellular glycogen.
Okay, let's pause there because this is where the biology gets really, really interconnected.
It does.
Glycogen is essentially a stored form of sugar.
Yep.
So why does the lack of sugar inside these cells matter so much to the overall health of the tissue?
It's all because of the local microbiome.
Oh, okay.
The healthy bacteria in the vagina, specifically the lactobacilli strains, they rely on that glycogen as their primary food source.
Oh, wow.
Yeah. So when the lactobacilli consume glycogen, their natural byproduct is lactic acid.
Oh,
And that lactic acid is the invisible shield for the whole region. It keeps the vaginal pH low, sitting in that slightly acidic range of about 3.5 to 4.5.
which is important because...
Because that highly acidic environment is totally hostile to pathogens. It prevents infections, wards off yeast, and keeps the tissue optimally lubricated.
Okay, so for a listener who might be, say, in her early 50s and is suddenly getting recurrent urinary tract infections or vaginal infections seemingly out of nowhere,
Right.
it's not that her hygiene has changed.
Not at all.
It is that this entire microscopic ecosystem has literally starved to death.
That is exactly it. No estrogen means no mature superficial cells. No superficial cells means no glycogen for the good bacteria.
Right.
The good bacteria die off, the pH spikes, and the pathogens just move right in.
That's a complete microecological collapse.
It really is. And the real-world symptom of that collapse is severe dryness, chronic burning, intense itching,
Oh, man.
and dyspareunia, which is the clinical term for painful intercourse.
Right.
The mucosal lining becomes so thin and so incredibly fragile that just normal, everyday friction causes micro tears in the tissue.
That sounds agonizing.
It is.
So that perfectly covers the epidermal dryness, right? The failure of the mucosal lining. But our mission question also mentioned dermal thinning.
Yeah.
And according to the sources, that is happening simultaneously, but the mechanism is slightly different.
Right, because while the internal mucosal lining is drying out and collapsing, the outer anatomical structures, specifically the labia majora, the outer lips,
Right.
they're undergoing a process called lipodystrophy.
Okay, breaking down that root word, lipo meaning fat, and dystrophy meaning abnormal change or breakdown. So we are actually losing the fat tissue.
Yes, with age and combined with the loss of localized follicular activity, the labia majora actually lose their subcutaneous fat pads.
Wow.
The fat cells literally shrink and disappear.
That's crazy.
And simultaneously, local collagen production slows down to a crawl. The connective tissue matrix just relaxes and loses its elasticity.
Right.
Even the vascularization, the network of blood vessels delivering nutrients to the area, that rapidly decreases too.
So the tissue is basically starving for blood, it's starving for structural proteins, and it's losing its physical volume all at once.
Exactly. And the clinical result is a deflated, wrinkled appearance, which some people mistakenly brush off as purely an aesthetic concern.
Like it's just about how it looks.
Right.
Right.
And it is decidedly not just aesthetic.
Yeah.
That subcutaneous fat serves a vital evolutionary functional purpose. It is a natural mechanical cushion.
Right. It's padding.
Exactly. It protects the underlying cubic bone and the much more delicate internal tissues from physical impact,
Right.
like during activities like exercising or horseback riding,
Yeah.
even just sitting in a hard chair, or intimacy.
Okay.
When that fat pad dissolves, your body's built-in shock absorber is just gone.
Man. Let me try to put a visual analogy on this because the dual nature of this breakdown is just fascinating to me.
Go for it.
It feels like a house that is simultaneously losing its structural foundation and its weatherproofing.
Oh, I like that.
Right. So the lipodystrophy, the loss of the fat pads and collagen in the labia is like the concrete foundation of the house sinking and cracking. Like the actual physical structure is giving away.
Right.
But at the exact same time, the loss of those plump superficial cells and the glycogen in the mucosa is like the roof leaking and the weatherproofing failing.
Exactly.
So the inside is fully exposed to the elements.
That analogy hits it perfectly. You are dealing with a dual action breakdown, a volumetric structural failure on the outside, and a cellular mucosal failure on the inside.
Which naturally leads us to why treating this effectively likely requires a dual action solution.
Yes.
So let us open up the first therapy discussed in our stack of sources. Topical estrogen.
Okay.
Based on everything we just discussed, if estrogen deficiency is the primary culprit, replacing that estrogen seems like the absolute gold standard for fixing the weatherproofing.
It really is. It is the first line of defense for a reason.
Yeah.
Because instead of taking a pill and sending hormones through your entire bloodstream.
Right.
Topical estrogens, which are usually prescribed as creams, dissolvable tablets, or flexible rings, they deliver the hormones strictly to the localized tissue that is starving for it.
And the sources outline the exact cellular machinery of how a topical cream can essentially turn back the clock on these tissues. And honestly, I found this part mind-blowing.
It is really cool science.
Let's break down the how. Like, how does it actually do it?
Well, it comes down to the chemical properties of the hormone itself. Topical estrogen, usually synthesized as estradiol or estriol, is highly lipophilic.
Okay, meaning it's fat-loving.
Exactly. And since the outer membrane of every cell in our body is a lipid bilayer, basically a double layer of fat,
Right.
the estrogen just dissolves right through it.
Oh, wow. So it doesn't even need a special transport mechanism or a gateway or anything.
No gateway needed. It slips right through the cell wall like a ghost walking through a closed door.
That's incredible.
And once it is inside the cytoplasm of the cell, it seeks out and binds directly to specific estrogen receptors, which are often abbreviated as ERs. So it's like finding a keyhole that was just waiting specifically for that molecule.
Yes, exactly. And once the estrogen locks into that receptor, something really incredible happens.
What's that?
This new estrogen receptor complex physically transports itself across the nuclear membrane and directly into the nucleus of the cell.
The control center where your DNA is housed.
Right. It then binds directly to the DNA, specifically targeting regions known as estrogen response elements.
Wait, so we aren't just moisturizing the cell. We are literally rewriting the active genetic instructions of the cell in real time.
We're turning genes on and off.
Wow.
The complex recruits coactivators, it regulates gene transcription, and it ramps up protein synthesis. It is basically sending a direct chemical megaphone message to the cellular machinery saying, wake up, start dividing, and mature.
And the tangible, real-world result of that genetic wake-up call.
Oh, give it a few weeks, and the tissue deeply fundamentally rebuilds itself.
Wow.
That fragile population of parabazole cells shifts back to thick, robust, superficial cells.
The plump ones.
Right, the plump ones. And the glycogen stores are replenished, which means the healthy lactobacilli have food again.
Oh, so the whole ecosystem comes back online.
Completely. They repopulate, they produce lactic acid, and the vaginal pH drops safely back down to that protective acidic level.
That's amazing.
The elasticity, the natural moisture, the resistance to friction, it all returns. It is a profound reversal of the atrophy at the foundational cellular level.
Now, I know a major concern for many listeners when they hear the words hormone therapy is safety.
Of course.
A lot of women have a deep-seated fear of traditional systemic hormone replacement therapy because of highly publicized past studies linking systemic HRT to things like blood clots or breast cancer risks.
Yes, that is a very common and very valid concern.
But our sources are very careful to distinguish topical application from systemic application, right?
Yes, the distinction is absolutely critical because topical estrogen is applied locally in very low doses. It has minimal to negligible systemic absorption.
Okay, so it stays put.
Exactly. It does its job in the pelvic region and doesn't significantly elevate estrogen levels in the general bloodstream.
That's great.
So for the vast majority of women, it is an incredibly safe and highly effective long-term treatment.
Right.
Though standard medical guidelines do still recommend that breast cancer survivors consult with their oncologist before starting, just out of an abundance of caution.
Makes sense. Okay, so here is where I'm going to push back on the premise of our deep dive a little bit.
All right, let's hear it.
If topical estrogen literally travels into the nucleus of the cell, rewrites the genetic code, completely rebuilds the mucosal tissue, fixes the pH, and brings back all the moisture,
Yeah.
why isn't that just the end of the conversation? I mean,
Ah,
if it is that miraculous, why do we need anything else? Why are we even talking about injecting dermal
that's
fillers?
a very logical question. I mean, if the magic cream works, why add a needle?
Right.
The answer lies in the harsh limitations of human biology and, honestly, the constraints of time.
Okay, time how?
First, estrogen takes time to work. You are entirely reliant on the speed of natural cellular turnover.
Right. Biology is slow.
Exactly. It can easily take 6 to 8 weeks of consistent daily or weekly application for a patient to feel any significant relief from the severe dryness and burning.
Uh, so it's not a painkiller or a numbing agent. Like, if you are in agony today, applying the cream today won't help you ride your bike tomorrow.
Not at all. You have to wait for the body to literally construct new healthy tissue from scratch.
Oh, okay.
You're waiting on a construction project to finish.
Yeah.
But the second, and perhaps the most immovable limitation, is physical volume,
Right, the fat loss.
right? Estrogen is unparalleled at rejuvenating the mucosal lining,
Hmm.
fixing the weatherproofing on our metaphorical house, like you said.
Yeah.
But it has absolutely no ability to instantly conjure up the subcutaneous fat pads that have dissolved in the labia majora.
Okay.
It cannot magically fix the sunken concrete foundation.
So even if the skin on the outside becomes healthier and more elastic from the estrogen, it's still deflated. The shock absorber is still missing.
Exactly. Lipodystrophy is a tangible physical void in the tissue. Estrogen just won't reinflate that lost cushioning
So it's a mechanical issue.
completely.
Mm.
If a woman is experiencing micro tears and severe pain while sitting at her desk because her pubic bone is literally grinding against the chair without any natural padding,
Ouch.
yeah, topical estrogen alone will never give her that physical bulk back.
Which brings us perfectly to therapy number 2, the foundation repair, labial fillers,
Yes,
specifically the clinical use of hyaluronic acid or HA.
right. This is where we directly address that structural foundation.
Okay.
The sources highlight advanced clinical-grade HA dermal fillers, products like Deserial and Deserial Plus.
Right, I saw those names in the text.
Yeah, they have been recusologically formulated specifically for the unique biomechanics of this highly sensitive pelvic region.
Well, let's unpack hyaluronic acid for a second, because I think the average person hears hyaluronic acid and they immediately picture, the hydrating serum they buy at a cosmetics counter.
Oh, for sure.
Or like the filler a plastic surgeon uses to plump up a celebrity's cheekbones.
Yeah, that's the usual context.
But HA isn't some synthetic plastic, right?
Yeah.
It's a naturally occurring biological molecule.
Yes, it is ubiquitous in the human body. Hyaluronic acid is a glycosaminoglycan.
A glycosaminoglycan.
Yeah, it's one of the primary building blocks of the extracellular matrix in our own connective tissues, our skin, and even the fluid that lubricates our joints.
Wow.
And its defining molecular superpower is its extreme hydrophilicity.
Hydrophilic meaning water-loving.
Extremely water-loving. Like a single molecule of HA can bind and hold up to 1,000 times its own weight in water.
1,000 times. That's wild.
It really is. So when a clinician injects this HA matrix deep into the labia majora, it acts as an immediate biological scaffold.
Okay.
It instantly attracts massive amounts of hydration from the surrounding tissues.
Which does what exactly?
It immediately restores the last plumpness, provides robust volume, and corrects any asymmetry.
See, I might have assumed that a dermal filler just sits there like a dumb, inert piece of silicone, purely taking up physical space.
A lot of people think that.
But the Journal of Menopausal Medicine makes a fascinating point that entirely shifted my perspective on this. HA is biologically active.
Yes.
Like it's doing work while it's in there.
It absolutely is. That is one of the most common misconceptions, even among some medical professionals.
Really?
Yeah. It doesn't just sit in the tissue-occupying space. HA actively interacts with specific cellular receptors located on the membranes of the surrounding cells, primarily the CD44 and RHAM receptors.
Okay, we definitely need to translate that. What is a CD44 receptor actually doing?
Okay, think of CD44 like a specialized doorbell on the outside of the cell membrane.
Okay, doorbell.
When the injected HA molecules bump up against the cell and ring that doorbell,
Right.
it triggers an alarm inside the cell. It sets off an intracellular signaling cascade.
Wow.
And one of the main pathways it activates is called the ERK1/2 pathway.
The ERK1/2 pathway. Extracellular signal regulated kinase.
That's the one.
Okay, how does that translate into actually repairing the tissue? Let's stick with the house analogy we had going.
All right, let us say the doorbell is rung on the ground floor.
Okay.
The ERK1/2 pathway is the electrical wiring that carries that signal all the way down to the basement where the fibroblasts are sleeping.
Ah, the
Yes,
fibroblasts.
fibroblasts are the builder cells of the body.
Right.
So the signal jolts them awake, promotes mRNA transcription, and tells them, hey, we need structural support up here, start pouring concrete.
Wow.
And the concrete in this case is natural human collagen.
That is just incredible. So the injected HA acts as an immediate physical water balloon, basically,
Right.
to provide instant shock absorption and relieve the friction today.
Yes.
But while it's sitting there, it's quietly ringing the doorbells of the local cells, telling the body's own builders to lay down a permanent collagen infrastructure for the future.
Exactly.
Yeah.
It's providing both immediate mechanical relief
Yeah.
and kickstarting long-term tissue regeneration.
That's brilliant.
And we also have to factor in mechanosensing.
What's that?
Well, simply the physical stretching of the deflated tissue by the physical volume of the filler creates a mechanical tension.
Okay.
The cells sense that stretch, and that physical force alone stimulates them to strengthen their structural integrity.
I am just struck by the ingenuity of this, taking the exact same base ingredient that the cosmetics industry uses to plump a lip for purely aesthetic vanity
Right.
and applying it for profound functional quality of life restoration. And we're talking about giving a woman the ability to run a marathon or sit in a board meeting without localized agony.
It's life-changing for patients. And I would also highlight how vital this mechanism is as a non-hormonal alternative.
Oh, right, because of the breast cancer patients.
Exactly. Consider women who absolutely cannot take estrogen under any circumstances.
Yeah.
For example, patients currently battling estrogen receptor-positive breast cancers.
For them, topical estrogen is completely off the table.
Completely. And they are often thrust into early severe chemical menopause with zero hormonal recourse.
Wow.
For those patients, HA injections offer incredible hormone-free relief for dryness, friction, and tissue laxity. It is an absolute lifeline.
That makes total sense. So, synthesizing everything we've explored, we finally arrive at the core mission question of this deep dive.
Let's hear it again.
Can labial filler augmentation be combined with topical estrogen therapy to treat concurrent dermal thinning and epidermal dryness?
Based on the overwhelming clinical consensus across all of our sources, the answer is a resounding, unequivocal yes.
Yes, it can.
Not only can they be safely combined, but they are dramatically more effective when utilized in tandem. Their mechanisms of action complement each other flawlessly.
So let's walk through what that dual approach actually looks like for a patient stepping into a clinic today.
Okay, picture a patient presenting with severe GSM.
All right.
She has profound mucosal dryness internally and significant lipodystrophy or volume loss externally.
So the foundation and the roof are both shot.
Both are shot. Now, if a doctor only prescribes estrogen cream, she is facing weeks of waiting for cellular turnover before she feels any relief from the burning,
Right.
and she will never fully regain that lost physical cushioning.
Because the cream can't build fat.
Exactly. Conversely, if the doctor only utilizes HA filler, she gets instant relief from the mechanical friction and immediate superficial hydration.
What?
But she isn't addressing the underlying hormonal starvation that caused her internal mucosal cells to atrophy in the first place.
She's fixing the foundation but letting the roof keep leaking.
Exactly. But when the therapies are combined,
That's the magic.
it is. When combined, you tackle the pathology from both ends. The HA filler is administered in the clinic. It provides immediate volumetric relief.
Right away.
The physical discomfort of friction stops that very afternoon.
Wow.
The severe superficial dryness is rapidly soothed by the massive water-binding capacity of the HA scaffolding.
So she literally gets her quality of life back on day one.
Day one, she can sit comfortably. She can move comfortably.
And meanwhile...
Meanwhile, the topical estrogen is quietly working in the background.
Right.
Day by day, application by application, those lipophilic molecules are slipping through the cell membranes, entering the nucleus, rewriting the genetic instructions, and fundamentally rebuilding the thickness, elasticity, and microbiome of the internal mucosal lining.
The HA acts as the immediate structural bridge, basically holding down the fort and preventing pain.
Yes.
While the estrogen acts as the general contractor doing the deep, long-term cellular renovations.
I love that. Yes. By combining them, patients get the robust volume restoration from HA that estrogen simply cannot provide, and they don't have to endure weeks of agonizing suffering while waiting for the estrogen cellular machinery to kick into gear.
It is a meticulously designed, comprehensive approach to tissue rehabilitation.
It really is.
Which brings us to why this matters so deeply for anyone listening. We are talking about medical interventions that can restore a person's daily dignity and comfort. The ability to maintain an active lifestyle, to travel, to maintain a pain-free, intimate life. This isn't just, abstract medical trivia.
Not at all.
This is deeply empowering knowledge. Understanding the specific mechanisms behind these treatments, knowing the difference between repairing your mucosal weatherproofing and restoring your structural foundation,
Yeah.
it empowers patients to have vastly better, more specific conversations with their healthcare providers.
Absolutely. The era of simply enduring the symptoms of GSM or VVA in silence is over.
It's over.
No one should accept this pain as just an inevitable consequence of aging. We have a highly sophisticated, effective toolkit now. Deep hormonal repair paired seamlessly with immediate structural hydration.
So we've established that combining targeted topical estrogen and HA filler is an incredibly synergistic approach to reversing severe localized tissue atrophy. But thinking about the underlying biology we just unpacked, where does this science take us next?
Well, if we zoom out and look at the bigger picture, it raises a profoundly provocative question.
Okay, what is it?
What we are really looking at here is a blueprint for localized anti-aging.
A blueprint.
Think about it. We are combining a targeted hormone to rewrite degraded cellular instructions with an extracellular matrix scaffold, the HA, to provide immediate volume and mechanical cellular signaling.
The dual mechanism blueprint.
Exactly. If we can successfully use this synergistic blueprint to completely reverse severe age-related tissue atrophy and structural collapse in gynecology,
Wow.
could this exact same dual mechanism approach eventually be adapted to reverse the aging process in our deteriorating joints,
Oh, wow.
or our degrading vocal cords, or even our vital internal organs before they ever reach the point of failure?
That is insane.
Right. If we can reinflate the physical cushion and rewrite the underlying cellular code simultaneously, the future implications for regenerative medicine across the entire human body are just staggering.
That is a massive concept to chew on. We started this deep dive talking about how historical medicine loved the visible, right? The X-ray, the obvious broken bone. But maybe the true future of medicine isn't about forcefully fixing what's visibly broken. Maybe it's about mastering this invisible, microscopic cellular environment so the breakdown simply never happens in the first place.
Now that is a deep dive for another day.
Without a doubt. Thank you for exploring this with us, and we'll see you on the next deep dive.